anxiety about that, about all of the things that are ahead. So I know that you know that this week your review for HIV and AIDS is due on Sunday at 11:59. That is open and available for you if you haven't started it already. Next Friday we will be having exam number 3, which is at 2 p.m. Central Standard Time. What I really want to talk about today is preparation for the final and the focused review. So there are a lot of people who've been texting me, or not texting me, but emailing me rather, and asking me to open up those practice exams. And I'm going to tell you that I have denied that request, which I don't deny too many requests. But the reason why I've denied that request is because I don't want you to get the cart before the horse. I want you to be prepared for exam number 3. As soon as you sit down to take that exam next Friday, the practice exams will open. I encourage you not to start on them on Friday. You know, after you take the exam, you need to decompress, have some self-care, whatever that means for you. And Saturday, I would start working on my practice exams. So you are, I want you to really take some time for yourself and get prepared for the last part of the class, okay? So when you get ready to do that, you are going to be taking 2 ATI online practice exams. You can take them in any order you wish. You can take the med-surg first and the mental health second, or you can take it, like I said, either way. First or whichever one you choose to do first and second. After you have completed those online practice exams, and you could do, if you wanted to, you could do 1 online practice exam followed by your 2-hour focused review, and then take the next test and follow it by the 2-hour focused review. That's however you want to take it is how you want to take it. I'm somebody who likes to cluster things, so I probably would take 1 exam and then I would do the focus review, and then I would take my second exam and do that focus review. So just so you know, there are 2-hour focus reviews that are required for both practice exams. So that's a total of 4 hours, okay? So those exams, the practice exams are due to be completed by August the 10th, okay? So you have quite a few days. You have 10 days to take those exams. And you have 4 additional days to complete the focus review and turn the transcripts into me on time. Any questions about what I've said so far? Is that clear? Yes, Carrot.
Yes, I was wondering why the 4-hour focused review was so late in the semester, because that's a lot that we have to try to study and try to go over. I mean, it's getting a little overwhelming.
Yeah, and it's not late, Carrot. It's not late at all. This is right on target, okay? It's in preparation for the final exam. This is a final exam prep for you. That's what this is, okay? And that's how come I designed the course the way that I have designed it, so that the last week, the week that we would have a live review, we don't have a live review. That is the time that is set aside for you to prepare for the final exam. So that is the way I designed it this way for a reason. Okay, so it's kind of intense studying, if you will. Does that answer that question?
I think so. So you're basically saying if we do that review, it'll help us with the finals, I guess?
Oh, definitely, definitely. That's what this is. This is preparation for the final. So remember, we took an exam similar to this,
Mm-hmm.
the first week of class. And this we'll just be adding on to this, okay? So I will open up a lot of things for you to utilize during that time. This is for you to close your gaps of foundational information.
Okay, and if the review doesn't, like the what do you call it again? The 2-hour thing?
The 2-hour focus review?
Yes, if the focus review doesn't take 2 hours, what, like, do we just wait for 2 hours and then turn it in?
Yeah, you have to have 2 hours minimum, and there is an exception to that, and that's on the next page, and I'll discuss that in a second. Okay.
Okay.
All right. So how you're going to submit them to me is your transcript to me. It's going to be in a single email. I'm not going to accept two separate transcripts, so it has to be in a single email. And it has to be submitted by August 14th at 11:59 to get credit. So now what am I going to look at on the transcripts so that I can ascertain the point distribution? I'm going to look for the date that you completed the online practice exam. I'm going to look for your minimum 2-hour focused review. And I'm going to look to see if you had a follow-up quiz that ATI gave to you, and you did, and I want for you to have completed that. Okay, not everybody will get that. It depends on your score. So that's why that is considered to me optional. If you have scored 100% on the practice exam, you are exempt from the 2-hour focused review. There will not be a 2-hour focused review available for you. Now, the minimum time for doing the focused review is 2 hours. I highly encourage you that based on your score, if you are doing really well, then maybe two hours is good enough for you. But if you're not doing as well as you would like to be doing, I highly encourage you to stay in there in that focused review for as long as is needed to close your gaps. Okay. Then our final exams will be Wednesday, August 17th and Thursday, August 18th. After you've taken those exams, I will pull the scores, and this is how you will be scored on the exam. So these are the levels over here to the left. This is the cut point for med-surg. The first column, second column is the cut points for mental health, and the third column is the point distribution that you will receive. So for example, in med-surg, if you score 82.1 or greater, you will receive 100%. So just know that these numbers are these are the cutoff numbers. So anything less than 56.7 will be a 50-point distribution. Okay, so these are the cut points. So this is a built-in curve. So in order to get 100 points, you do not have to make 100 on the final. So you have to make an 82.1 to receive 100 points. Does that make sense? So the curve is already built in. And then I don't want you to forget about tutoring. I don't know where Lilo is with regard to the final exam prep, if she's started already, but if you are attending her group sessions, or if you're not, I highly encourage you to do so to prepare for the final, okay? So I will post this so that you can look at it, and you'll see the point distribution and all of the reminders that are here for the due dates and the requirements to get those 100 points for the focused review. Any other questions? Okay, so we'll get started for today then. So what we're going to do today is we're going to do 2 case studies. So I have a rather lengthy PowerPoint for you, and so there'll be some things that are on the PowerPoint that won't be covered today. So we're going to do, like I said, 2 case studies, and then I have added extra slides in there on the other topics. And what I did is I went ahead and put some information down in the notes section for things that might be important to you as you review those slides. So this will be interactive today. Okay. Let's see. I can post them on Blackboard. Alyssa, if you'd like me to, I can do that. Okay, no problem. I can do that. So let's talk first about the thyroid. We'll talk just a little bit about the thyroid spectrum. So the thyroid spectrum, of course, we all want to be in the middle, right? euthyroid, that's homeostasis, where we all want to be. But we could be on either side of the spectrum. And hyperthyroidism can lead to thyrotoxicosis, thyroid storm. And on the other side is hypothyroidism, which is myxedema coma. That is the sequela of advanced hypothyroidism. So when we talk about hyperthyroidism, when you're thinking about differentiating the signs and symptoms associated with these disorders, remember that hyperthyroidism, everything is sped up, so that you have a hyper metabolic rate, and conversely, in hypothyroidism, everything slows down. Okay, so our first case study is going to be on hyperthyroidism and Graves' disease. So you'll see this green slide here, and when you get those slides, you'll see that, I don't know if this slide has information on it, but the ones that say student supplemental, those are things for you to read, okay? I just added those additional slides for you. So what I want you to know about hyperthyroidism and Graves' disease is autoimmune. So it's an autoimmune disease, and in hyperthyroidism, patients are excreting, they have too much thyroid hormone, and so women are more likely to develop hyperthyroidism than men are, I should say. And usually the highest frequency is between the ages of 20 and 40 years old. But you'll see that our example is going to fall outside of that norm. Okay, so let's, who wants to read the case study? Okay, Carrot, I'm ready for you. There's several slides here, okay? And I broke it down so that you guys could kind of follow along instead of having it all in just one big paragraph.
Okay, KB is a 65-year-old man admitted to the hospital after a 5-day episode of the flu with complaints of dyspnea on exertion, palpitations, chest pain, insomnia, and fatigue. KB was diagnosed with Graves' disease 6 months ago and placed on methimazole, tapazole, 15 milligrams a day.
Okay, so he has Graves' disease, okay?
Mm-hmm.
So there's the next part.
His other past medical history includes heart failure, hypertension, requiring antihypertensive medications. However, he states that he has not been taking these medications on a regular basis. Vital signs, his blood pressure is high with 150/90. Height, do you want me to read all of those?
Yes, please.
Oh, sorry. Heart rate 124, irregular, respiratory rate 20, temperature is 100.2, his height is 65 inches, and his weight is 60 kilograms.
Okay.
So he's a small guy with high blood pressure and everything else wrong.
Yeah, he only weighs 132 pounds and he's 5'8".
Mm-hmm. The patient appears anxious and restless, loud heart sounds, 1+ pitting edema noted in bilateral lower extremities, diminished breath sounds with fine crackles in the posterior basis. KB begins to cry when he tells you he recently lost his wife. You notice someone has punched several more holes in his belt so he could tighten it. His labs, his hemoglobin 11.8, hematocrit 36%, his ESR is 48, sodium is 141, potassium is 4.7, chloride 101, his BUN is 33, creatinine is 1.9, his free T4 is 14.0, and his triiodothyronine is 230. His T3.
Yeah, it's T3 basically. So this is just for you. This slide is just for you as you're working through the slide deck. Okay. All right, so which of KB's assessment findings represent manifestations of hypermetabolism? Out of the things that Carrot told us, what are the things that tell you that this guy has hyperthyroid or hyper metabolism? Weight loss, very good. Increased blood pressure, heart rate, and temperature. What else? Okay. All right, so that's high blood pressure, right? It elevated T3, T4. Let me go back here. Anything else? Fatigue, because he has an increase in increased metabolic rate, probably. Palpitations.
His
Mo, what
dyspnea on exertion.
dyspnea on exertion? He's anxious. That's what the nurse observed, right? That he's anxious and restless. So I think somebody said, this is a side question, but for the exam where we need to know, I would know them. Yes, I would know them. Lost my train of thought where I was with that.
You said he's anxious and restless.
He's anxious and restless. And then Carrot brought up something. I think somebody said, I'm not exactly sure what the first person said, but remember that he has a low weight to height ratio. And of course, he has some holes in his belt, so we're cinching it up because he has weight loss. So we know that in hyperthyroidism, that these things are an increase in metabolic rate. So you're going to have weight loss. And in hypothyroidism, you're going to have weight gain. Okay. Okay, so let's talk about the labs. Do you guys need to go back to this labs slide? So what is wrong with the labs? The H is low. Are you mean hemoglobin? The hemoglobin is low. The creatinine is high. The BUN is on the higher side, right? Yes. So what would the BUN tell you? Elevated T3, T4. Let me see. Hemoglobin, yes. So elevated T3 and T4, we know that in hyperthyroidism, the T3, T4 are going to be elevated, but what happens to the TSH? It's very low, very, very low. So to me, it's the opposite of common sense. So free T3 and the kidneys may not be working so well, but remember that this patient has a history of heart failure too, right? So we have to kind of look at the picture. So what do you think about the SED rate? Is that high or low? It's on the higher side. So we would want to be thinking about that. And we also would want to be thinking about why would this guy be having a lower than normal H&H? And it could be caused from his hypermetabolic state. It surely could. Or it could be because he has chronic illness, okay? And his kidneys aren't working very well. So what hormone, anemia, kidney, what's the hormone, Mo, that the patient is missing? E, erythropoietin, right? Erythropoietin. So we don't really know what's going on with this patient. And sometimes we just don't know when they come in. So let me go back to the slide deck. I wish it was always clear, but it's not. Okay, so You go in to assess KB with additional, what additional data do you need to obtain because he has Graves' disease? What do you need to do? How are you going to approach this patient? What meds is he supposed to be on? Okay. And the other question, what meds is he supposed to be on? And what else would I be thinking? Vital signs. And I would also be asking myself, is he taking those medications? Dysrhythmia, vital signs. So what's the first thing that we do? Abby just said the word that I'm looking for. What do we do first? What do we do first? Abby just said we assess the patient, right? We do an assessment first. We try to get information about the presenting symptoms, right? We're going to be doing a deeper dive into, tell me more about your fatigue, tell me about your insomnia. And so think about that. Just think about fatigue and insomnia, and another piece of that scenario that might be contributing to his insomnia and his fatigue. What might that be? And sometimes these things are not physiological. Yeah, the loss of his wife, that stressor that he's having. So is this part of the disease process, or is this a side effect of an emotional trauma? And of course, we want to know more about the chest pain. We're going to really delve into that. We're going to also look at his dyspnea. And we know that he has heart failure and also his palpitations. So those are the things that we are going to look at. Now, what are some of the other things that thyroid can cause? It can cause problems with memory, right, and concentration, especially if you're in the hyper state. It's very hard for people to concentrate. What are some of the other things that you might want to look at? Think about what a patient that has hyperthyroidism, what might they present with? What else are you going, what other questions might you ask? Eyes. What about the eyes, Carrot? Coming out, okay, protruding, right? Is he protecting them? Mental fog, I like that. I don't know, I can't see all of those, but let me go over there. Yes. Yeah, you want to know if he's having any problems with his eyes. Is he having any photosensitivity? That would be one that I would think about. Are you photosensitive, and are you protecting your eyes? Are you able to close your eyelids at night, right? And these individuals also have some diarrhea, sweaty, very good. What else? What about appetite? Weight loss, and they might be eating like a horse and still losing weight, right? Bowel habits, amenorrhea, very good, guys. Emotional lability also, okay, so they might just be very labile. So what about if I have too much thyroid on physical exam? What is one of the things I'm going to test for if I think the patient well, I know the patient has too much thyroid because it shows in the T4. Okay, that's a complication, right? That's a complication. So we already said, Michelle, that we're going to do TSH. We know it's going to be low. Thyroid storm, yes, which is a complication, but what physical assessment are you going to do if your patient will be heat intolerant, and their temperature is going to be elevated too, right? They're not going to want to be living in El Paso. You're going to want to be doing deep tendon reflexes, okay, because they're going to be in neuro assessment. Yes. Is there a goiter? Yes. Those are the kinds of things that you're going to want to be looking for, okay? Are there any visual changes? Do you have diplopia? Do you have blurred vision? Are you experiencing any eye pain? What happens to hair, skin, and nails when you have one of these disorders? You know, you have changes in your hair, skin, and nails. All right. Thyroid plays a huge role, and thinning is and a lot of that stuff also is on the hypothyroidism. Um, Here we go. These are the things that I gave this extra slide to you. So you might have weight loss, intolerance to heat. We didn't say palpitations, right? We didn't say palpitations, but we should have. Somebody said diarrhea, muscle weakness and tremors, and that's why we would be looking for the deep tendon reflexes, anxiety and insomnia, which our patient has, changes in your menstrual cycle. We might have an enlarged exophthalmos, enlarged thyroid gland, or the exophthalmos, which is the bulging of the eyes. And if you've ever seen anybody with exophthalmos, you will never forget it, okay? You will never forget it. So let's go on to the next slide. Saw on a commercial, oh yes, and so Carrot, did you see that that there's a new eye drop out for people without exophthalmos? Is that what you saw? To help with, yes, to help with regression. Yes, that's fairly new on the market, and I think that I know that it's a temporary solution, so they have to put those eye drops in, I don't know how many times per day, but it's going to help with some of those thyroid eye disease problems. So yeah, very good, awesome, great. Okay, so the physician or the provider writes the admission orders. Which orders will you question and why? So the order is propranolol 20 every 6, dexamethasone 10 IV every 6, verapamil, which is 120 PO, I guess, per day, Lasix or furosemide 80 milligrams IV push now, and then 40 milligrams IV push daily. Diet is tolerated, a stat EKG and echo, up ad lib, IV at D5W at 125, daily weights, INO, strict INO. Which ones are you going to question as the nurse? Are you going to give all these things and do all these things? And if you're not, why not? What would you question? Oh.
The Lasix.
Why? Okay, why furosemide? It's a diuretic, okay. Already small, all right. So what else are you going to question? The K and the EKG. There is no K.
I mean for the furosemide.
Oh, okay, all right, okay. You need a furosemide. You need a potassium level if you're going to give furosemide, okay. Anything else? So your patient has a history of heart failure. So your patient has palpitations, and he also has chest pain, right? He also has chest pain, and he has 1+ pitting edema. Oh, the fluids. Okay, Alyssa, why would you want to question those fluids? Why would you want to question them? You're right. Yeah, the patient has a history of CHF, and not only that, it also, is this an isotonic fluid? No, right? No. Okay. So definitely we need this stat EKG and echo. Would you question daily weights or INO? Would you question that? No. Would you question his activity? No. Okay, so I agree with Carrot. I would question that. And why would I question? Why would you question it? What in the scenario would make you question it? I like to hear everybody's, he's tachycardic, okay? His heart rate is irregular too, right? He's a fall risk. Oh, he's got chest pain also. He has a history of heart failure. And what happens to the myocardial oxygen demand in patients that have hyperthyroid? It increases, right? So, you know, I don't know if I have any ischemia going on there. I know that I have chest pain. I know that I have an elevated heart rate. I know that it's irregular. And so I don't want my patient, yeah, we don't know. I don't know what that is. I don't know if he has that. That's why we're getting a stat EKG. I don't know if he has AFib, but it certainly is a possibility, right? So I probably would question that. And I also, so tell me what propranolol is and tell me what verapamil is. What is the drug class for, okay, which one is, okay, so propranolol is a beta blocker and verapamil is a calcium channel blocker. You know, we have to be careful with our patients that have CHF, heart failure. So I would want to question that because it could have a negative, yes, we have to be careful because we have to really evaluate that whole situation, because if your patient has a decrease in cardiac output and the heart failure is out of control, then we might want to think about some other type of therapies so that the patient can have a greater benefit from other medications. Okay, so he might have acute on chronic heart failure. Do you know what I mean? Do you know what I mean by that? He might have been very stable on his medication regimen, but something upset the apple cart, and now we have an acute situation. And Michelle, you're correct. It's an exacerbation of a chronic problem. And when they come into the hospital, we call that acute on chronic. So we have to look at what medications they're on, and we have to make sure that we're not going to cause a greater problem, because we need to assess that ejection fraction. We need to be looking at echo. So, so that's why we're getting this echocardiogram, because we need to look at the function of the heart. And this is the least innocuous way to do so. Does that make sense, guys? Okay. All right. Good. All right. Next slide. When I go over to your comments, my slides, I don't know what my next slide, I can't get to my next slide is what I'm saying. Describe four priority problems related to the nursing care. So we already described one. We have a probable decreased cardiac output, and we have that because we know, what are the two influencing factors of cardiac output? What are the two influencing factors? Heart rate and stroke volume. So those two things influence cardiac output. And we already know that the patient has an irregular rate, right? We has an irregularity. And we also know that he's tachycardic because his rate is at 120. And we also know that he has a history of heart failure. So we don't really know what's going on with that heart failure, but we do know that there's a probability that he has a decrease in cardiac output. What else can you think of that, that are problems that would be something that you would want to look at? Remember that he's in a hypermetabolic state. So what do you want to be thinking about? And what do you know from your scenario? His blood pressure, okay, which would go with which would go in the category really of cardiac output, right? Cardiac. What about his temperature? Cold, salt, weight, vital, dyspnea. Ooh. Yeah, he's hyperthermic right now, And he has a potential for hyperthermia just because he has increased heat production because he has hypermetabolic rate. What happens to oxygenation? The demand increases. So aren't you going to be checking his O2 sat? Maybe doing some of the interventions that you know how to do when people start to desat, which would be what? What would you do for those kinds of people? High Fowlers, or Fowlers at least, right? 30 to 45 at least. Maybe supplement them with a little oxygen if necessary, or maybe we're just not there yet, right? But we have to be thinking about that. We have to be thinking about if the patient is oxygenating well. We also have to be thinking about nutrition, right? Is the patient actually eating? Is the patient just losing weight? His psychosocial situation might also be playing a role in. So if we had some nutritional deficits, how would you know that in laboratory data? What would you be looking at? Albumin and protein, total protein and albumin, very good. All right, he might also be dehydrated. He could be on the dehydrated side if he's not eating or drinking very well. What about elimination? What would you want to be thinking about there? What goes along with an increased metabolic rate for the GI system? Somebody already said that they might have diarrhea, but yeah, we might have an electrolyte imbalance. So don't forget about why you're actually thinking about that. And so, and then we already talked about his tolerance to activity. So he could have some metabolic alkalosis, and as far as his activity, he's going to be fatigued and weak, and especially if he's in heart failure. And so we also need to be thinking about, for our priority problems, of course, the ones that we talked about are more priority than education, but we're going to have to educate this patient about what the disease process is if he's not aware of that, and how important medical therapy is to maintain, to get into euthyroid and to maintain that. Because that's what we're always trying to do in therapy, right? We're trying to get somebody to euthyroid. Later on in your shift, you note that KB is extremely restless and disoriented to person, place, and time. His blood pressure is increased to 174/82. His heart rate is now 180 and still remains irregular. His respiratory rate has creeped up to 32 and is labored. His temperature is now 104 degrees Fahrenheit, and his EKG shows atrial fibrillation. So whoever said that, that was a great thought process. What would your pulse be in atrial fibrillation? We have, I don't know if you guys, I don't know if you were taught this in health assessment, but we have regular, we have irregular, and we have irregularly irregular, right? So in atrial fibrillation, it's a chaotic rhythm, right? So you can't make heads or tails out of it. So we call that an irregularly irregular rhythm. Yep, there you go, Carrot. That's exactly what that is, okay? What is likely happening to the patient now? And tell me why you think that. Yeah, you think he might be in thyroid storm or a thyrotoxic crisis, right? It sounds like that. So now let's talk about how you're going to approach this thing in a methodical, in a methodical manner. What are you going to do first? Okay, ABCs, I love it. Airway, breathing, circulation, okay? So now you've had a change, you've had a significant change in your patient's status, and he might not do so well. So what would you do first? What might you do first? Not a trach setup. Okay. And you're not going to orient him also. Okay, so what I would do here first is I would address the breathing, okay? So he is 32 and he's labored, so that means he's dyspneic, right? So airway, O2 if needed, circulation, BP, heart rate stable. Okay, so now what would I do? So I know he has I know that he has atrial fibrillation. I know that he's very hypertensive. His heart rate is pretty elevated. So this would be atrial fibrillation with RVR, rapid ventricular response. And how do you know that? How do you know that it's RVR? What is the criteria? It's more than 100. Yes, more than 100. Awesome. That you have to be able to define that. Okay. So what I would do is I would call a rapid response. I would call a rapid response and I would get some help. Okay. I would get some help. So now you have to call the provider. You have to call the provider and you have to let them know that there's been a change in the patient's status. So I want somebody to give me the situation. Tell me, if you were going to call me and tell me about this patient that you're having, pretend that you're going to be calling me and you're giving me the situation. Who wants to do that? I don't want to choose somebody. How about you, Abby? What's the first thing you're going to say when you call me and give me the information about the status change?
First thing I'll tell you is obviously patient, where I'm at, who I am, and then the situation with the vitals, 174/82, the temperature, obviously how the patient is presenting, restless, disoriented, and showing signs of AFib.
Okay, and confused. Don't forget confused. So before we remind me to come back to that, Abby, if I don't. Okay. So Michelle, give me the background part. What would you tell me in the background?
I missed the first part of the case study, but from what I've gathered, the background would basically be his history. So what he's been dealing with chronically, and then what he came in with. So his chief complaint.
Okay, so you would tell me that, you know, what you're exactly right. The situation, I'm sorry, the history, that when he came in, he had 1+ bilateral pitting edema. He had some diminished breath sounds, and he already had some crackles in the basis, right? Okay, Christian, give me the assessment portion of SBAR. How about you, Mo?
Assessment would be his vital signs, obviously. So his vitals is his previous vitals before he went to the storm, and the new vitals with the irregular pulse and his labor breathing. I'm going to give that to him as assessment.
Okay. All right, and don't forget that you're also going to tell me what you have done for any interventions that you have done. Okay. Don't forget to say that, you know, I pulled the head of the bed up and I put him on 2 liters of O2 and he's now saturating 92%. Okay. So your recommendations, Racine, what's your recommendations?
I would definitely, can you hear me? Can you hear me okay?
Yeah, I can now.
Okay,
Yes.
perfect. So with the atrial fibrillation, I would definitely give him some medication for that, for sure.
Okay.
There's no one I can think of.
If your patient is on the floor, do you want to keep him there, Racine?
No, maybe, do you mean like get him into a room, or what do you mean? Like,
I mean, if he's on the unit, if he's on, let's say, a med surg unit or telemetry, do you want to keep him there? Where do you think he should? Where do you think he would be best served?
no, is it ICU or?
Yeah, he needs to be going to a monitored unit, right? So he needs to be going probably to ICU. And so, you know, you're hoping that whoever you're calling is going to come in and see the patient, and that's what you should be expecting the orders to be. You should be expecting the orders to transfer, and you should be expecting the provider to say, yes, an ICU bed, yeah, a monitored bed somehow. Either it's a step down unit or ICU, and of course that's hospital dependent, right? So very good, guys. Good critical thinking. Okay. And I think that we might have already answered this question. Let's see. I think I missed a slide or not. What is likely happening with KB, which you already told me, right? And did I go backwards? Yeah. What will you do first? There you go. So this is management. So we'll go back to that. So now your patient is in critical care, and these are the orders. So you're going to give O2 at 2 liters stat. You're going to get a set of ABGs. You're going to get a BNP. What are we going to get a BNP for? Heart failure. We're going to get some cardiac enzymes because chest pain, and also the patient is in atrial fibrillation, and the heart rate is really high, so we're creating an ischemic situation, right? We're having a hard time with cardiac output. We're going to give some DIG 0.25 and then repeat it as necessary. We can give some diltiazem, what drug category is that in? What drug category is diltiazem? That's a calcium channel blocker. And so you're going to give this in a titrating dose. You'll give a bolus of 0.25 milligrams per kilogram. And then after 15 minutes, you can give a second dose if the heart rate remains greater than 140. And then you're going to increase the patient's methimazole to 15 milligrams every 6 hours. And then you're going to give Lugol solution. This should be 10 drops, POTID, and you're going to start 1 hour after the first methimazole dose is given. Okay, so you're going to give Lugol solution an hour later, and you're going to give some hydrocortisone. You're going to have absolute bed rest. So here we are. We're not going to increase that cardiac demand anymore, and you're going to give some Tylenol because your patient has some temperature. Does that make sense to you? Like why your orders are going to be that way? Do you understand the rationale for that? Yes, okay. So describe how you would take care of KB in the next hour. So of course our priorities are always ABC, and you guys already know that, and I think that's fabulous. So we've already taken care of the airway, right? So we've already taken care of breathing so far. So what are you going to be looking for with regard to cardiac? We already know the patient has palpitations. We already know the patient has an irregular rhythm. We know the patient has atrial fibrillation. But how are you going to know what are some of the things you're going to look for with regard to heart failure, exacerbation? Lung sounds, and we know that he's diminished with crackles, frothy sputum, JVD, don't forget JVD, okay? Think about your heart failure signs and symptoms, and then what meds are you going to give? Tell me what other meds you're going to give. You're going to give your cardiac meds, right? You're going to give your diltiazem. You're going to give your DIG, for sure. You're going to, and then remember how you give your methimazole. So how do I give that in comparison to my Lugol solution? So when you give your methimazole, you need to know what time you've given it so that 60 minutes later, you can start your Lugol solution. So with regard to some of the other things, you want to get those ABGs because you're worried about changes in pH, correct? Because you have a decrease in cardiac output. So what would happen to your pH? Your pH will be, if you have a decrease in cardiac output, yeah, you're going to be acidic. You're going to be acidic. So your pH is going to drop. So it'll be less than 7.35, right? Think about that. Think about that. And your BNP is going to go up. And depending on what's going on with the cardiac system, we need to know what those enzymes, what the troponins are, okay? And of course, we already talked at nauseum about the metabolic demand. We don't want our patient to be out of bed. We want them to have a lot of rest, okay? So make sure that you're monitoring the heart rate. Make sure that you are giving the appropriate amount of medication to bring that heart rate down. If your patient's an AFib, besides a calcium channel blocker, what are some of the other things that you want to be thinking about that you might be adding to your regimen? You should already know this. What else is an anticoagulant? And amiodarone. Why amiodarone, Mo? Why amiodarone?
AFib, because he has AFib alveolar, so that will bring it down.
The amiodarone is an antidysrhythmic, right?
Correct.
So amiodarone is used to hopefully convert the patient from AFib into normal sinus rhythm. So it's an antidysrhythmic, and diltiazem is a calcium channel blocker, and its first response is cardiac. So it's the one that's going to help bring our heart rate down. Okay, so in AFib patients, remember that we use some kind of anticoagulant, we use an antidysrhythmic, and we use a calcium channel blocker or a beta blocker to bring the heart rate down. Does that make sense? Okay, good. All right. Now let's talk about Lugol's solution. Describe how you're going to give Lugol's solution. How are you going to give that? IV, PO, PR, NG. Is it oral? Is it IV? Yeah, put it in the, yeah, it's PO, right? Yes, and you're going to use a straw. And remember that, and what else are you going to do with it? You're going to mix it with some kind of a juice. Some people use orange juice. You need to suspend it in some kind of liquid because it tastes terrible. It has a strong taste. I've never tasted it. And you want to use a straw so that you don't the patient doesn't discolor their teeth, okay? And give it after a meal. Okay, thank you for adding that, Christian. Okay, what is your primary nursing goal at this time? What are you trying to do? You can't really, at this point, we're giving the methimazole, we're giving the Lugols, but what we're trying to do is manage the side effects that are being caused by this excess thyroid hormone, okay? So we need to support the patient and especially the respiratory and the cardiac system and maintain the patients in a safe status. That's what our goals are, okay? Why was KB at risk for developing the thyroid storm? Well, what made him at risk? What put him at risk? Did we take it out? No, not yet. Yeah, no, we didn't. Not taking his meds as scheduled. He wasn't taking his meds, and the stress, right? The stress that he had, the major stressor, maybe that viral illness that he had. He complained of having the flu. Not to mention that the trauma of the loss of his wife, and he was already previously diagnosed with Graves' disease. He had been on Tapazole at home to manage that, but he wasn't taking the medication. He probably wasn't taking that medication, and he probably wasn't taking any of the other medications that would have controlled his heart failure. So very good. Okay, I'm glad to see that you guys got that. You got the stress and everything else. So the next slide is going to be just for you. This is just gives you kind of the complications associated with a thyroid storm. After several hours of treatment, KB's condition stabilizes. The physician discusses 2 treatment options with KB and his family: radioactive iodine therapy, I-131, or a subtotal thyroidectomy. This is a thyroid. This is extra for you. Okay, this is just extra when we're talking about a subtotal thyroidectomy. Okay. I want to go, so I think I must have missed a slide here, but basically, if the patient chooses to get radiation therapy and they ask your opinion about the radiation therapy, how would you, what are some of the things that you, the nurse, would say? Flush 3 times. Ooh. Oh, okay. So that is okay. All right. That I see what you're saying. Family and friends, elevated conditions, and I think I have that on the next slide. But here, they need to know what the risk and benefits is of either procedure, right? And a lot of times, people, just the word radiation, doesn't that give you a little a palpitation? Just if you hear the word radiation, and there's a lot of misconceptions out there about radiation and what it's going to do to you and how it's going to affect your family members. So we want to help them to understand, and it determines the function of the thyroid. Yeah, we're killing it off basically, whether we remove it surgically or we use radioactive iodine. So we're killing it off. So what they need to know is that they're going to have thyroid replacement hormone for the rest of their life. Okay, they actually have no thyroid, and you need to understand how important the thyroid hormone is and actually what it targets in our body. So they're going to have lab work. They're going to have to take the medication on a regular basis. They're going to have medication adjustments regarding a synthroid or levothyroxine. And it's kind of concerning because this gentleman already is not taking his home medication, and this is something, it's kind of like our organ transplant patients. They need to be on anti-rejection medication for the rest of their lives. So we have to make sure that the patient is going to be ready for that. Okay. And how can we support him or her at home? What's some of the ways that we could support them when they get home? Are you going to go home with them? No, you're not. So who can help them at home? What's your resource when you discharge them? You're going to send them out into the world? Family might be an answer. Maybe he doesn't have any family. Maybe it was just him and his wife. You guys, who's your resource when the patient goes home? family, home health, social services, yes. Okay, so don't forget about what your resources, because you can't do it all and you're not going home with them, all right? Okay, so KB decides to receive the radioactive iodine. During pre-treatment instructions, the family asks whether he will be radioactive and what precautions they should take. Outline the important guidelines for instructing KB and his family regarding home precautions. So I think you guys already got that one, but let's hear what you got to say. Is he going to be radioactive like we talked about in cancer when we talked about the seeds? Is he going to be radioactive like that? No, he's not going to be radioactive, right? He shouldn't be. Of course, it's always dose dependent. Okay, so Carrot said we're going to flush twice, right? No sharing of utensils. Very good. Flush the toilet twice. How long are you going to make him flush the toilet twice? We live in Texas. We have a problem with water. How long? 24 to 48 hours. 24 to 48 hours after he receives the treatment. That's how long he's going to double flush. And so you also want to instruct them that they wouldn't want to be kissing anybody, and they would want to stay away from a baby or a child for up to 72 hours. Okay. Shouldn't be around pregnant people either. No, nope, no pregnant people. All right, just as a precaution, Okay, let's see what the next slide shows. Okay, so this is your person, your patient that has exophthalmos. Okay, so do you see the eyes there? And then down here is the goiter. Okay, so this is just a picture of what they might look like. That should be, I think that came straight from your textbook. So the next set of slides is on hypothyroidism. So you need to be thinking about how does hypothyroidism differ from hyperthyroidism, and what is the emergency associated with hypothyroidism, which I already told you is myxedema coma, okay? So these slides will be on there for you. Okay, so we're going to talk here, we're going to be talking about Cushing's, and that'll be the last thing that we talk about first, okay? All right. Okay, so these are some of the foundational things that you should ask yourself, and if you don't know them, you might want to look it up. Where are the adrenals located? Well, they're located on top of the kidneys. They're perched on top of the kidneys. What hormones are secreted by the adrenal gland? And it depends on what portion of the adrenal gland we're talking about. Oh, I have that twice here. What is the function of cortisol? Remember that cortisol is very necessary for health and for life. And what is the function of ACTH? Those are the things you need to be asking yourself. And I'm pretty sure I have notes on that for you, okay? So this is a pretty long scenario, but I want you to be paying attention to it, okay? So JS has an order for home health. He has been assigned to your team. He is a 60-year-old male with chronic obstructive pulmonary disease related to cigarette smoking. He has home oxygen at 2 liters per nasal cannula. Approximately 10 months ago, he started on chronic oral steroid therapy. His current medication regimen includes ipratropium, albuterol, beclomethazine, dexamethasone, DIG, and furosemide. So which, out of this scenario, which of in the medication regimen, which ones are steroids? Which ones are steroids? The beclomethasone and the Decadron. So when I have a patient that is an asthmatic or a COPD that has like a double whammy, I'm always very nervous about that, okay? So you've got the medications, right? And he's got COPD, he's a smoker, he has home O2, and now he's on chronic steroid therapy. On the way to JS's home, you make a mental note to check him for signs and symptoms of Cushing's disease. Why do you want to do that? Why did I tell you that it makes me nervous when I have somebody on chronic steroid use, inhaled and oral? Okay, well, definitely there's infection risk, but remember that patients can get Cushing's if it's iatrogenic, right? Cushing's syndrome, and I should have put syndrome instead of disease. So usually Cushing's syndrome is iatrogenic, right? We cause it. We cause it by the medication that we give to them. So they're on long-term steroid use, chronic steroid use, synthetic glucocorticoids, okay? So this is an example of the many patients that we see in our practice, and we'll talk about that in a minute, who are on long-term corticosteroid therapy, all right? So they're at risk. So when you see them, you need to make sure that you're that's one of those things that you have in the back of your head, the back of your mind, that this is a risk, okay? And I need to be assessing the patient based on that. What is the difference between Cushing's syndrome and Cushing's disease? What is the difference? They both are exposed to too much cortisone, right? Cortisol, I should say. I already told you what Cushing's syndrome comes from, right? Is from outer use of steroids, from chronic use, right? Chronic use of synthetic glucocorticoids. And why do we have Cushing's disease? Why do people have Cushing's disease? What is the cause of that? Those patients overproduce ACTH. Okay, ACTH. They produce too much. They produce too much ACTH. Okay, and that comes from the pituitary gland in the brain. Okay, so they're producing too much ACTH, and sometimes it's because they have a tumor. They have a neuroendocrine tumor. They could have a lung tumor. They could have a GI tract tumor and a pancreatic tumor that can cause the production of too much ACTH. Okay. So one is we cause it with synthetic medications, which is syndrome, and the disease is because there's an overproduction of ACTH for some reason. Okay, so your assessment includes the following findings. Determine whether the findings are attributed to JS's COPD or possible Cushing's syndrome. Place an L beside the symptoms consistent with COPD and C next to those consistent with Cushing's syndrome. So what is barrel chest? Okay, all right. So let's do this. If it's Cushing, let's say Cushing. If it's COPD, let's put COPD. So the first one is COPD, right? We get a barrel chest with COPD. What about a moon face? That's Cushing's, right? What about an elevated blood pressure? Ooh, I gotta go to your, okay, that's from Cushing's. Why is that? Why do we have an elevated blood pressure with steroids? Sodium, right? We retain sodium, and where goes sodium, so goes water. So we have fluid retention, so that will drive up your blood pressure. What about pursed lip breathing, especially when your patient is stressed? What does that cause from? COPD. Okay, you're right, COPD. What about striae over your trunk and thighs? What is striae? What is striae? Stretch marks, right? Purple stretch marks. Bruising on both arms. It's probably, yeah, it's caused from Cushing's. What about acne? Cushing's, that's Cushing. Diminished breath sounds throughout the lung fields. That's COPD. What about truncal obesity with thin extremities? What about the supraclavicular and posterior upper back fat? That buffalo hump. It's called a buffalo hump. So you should have a mental picture in your mind of what your patient's going to look like, okay? They're going to have truncal fat. They're going to have a lot of stretch marks. They're going to have a moon face. They might have a hump. Their face, they might have acne. They might be bruising, okay? So have a mental picture of what your patient might look like, okay? Hirsutism, yes, hirsutism. I love it, Harry. You inform the physician of JS's assessment. The physician believes JS has developed Cushing's syndrome and decides to change his prescription from dexamethasone to daily prednisone given on alternate days. Explain the rationale for this change. Why do you want to change the medication? He still needs the steroids, but what is the difference between the Dexa and the prednisone? Why would we change that? Which one suppresses the access longer? Longer acting, shorter acting, yes. You're right. Which one is which? So the Dexa is longer acting, right? So it creates an adrenal suppression that lasts 2 days or more, 2 or more days. We don't know exactly, right? And it's not suitable. You know, we wouldn't want to alternate Dexa, all right? Whereas prednisone has a half-life of 1 to 1.5 days, and so that's one medication that we can alternate because it's shorter acting. Does that make sense? So you guys need to kind of, you know, the steroids are a little bit difficult. So Dexa crosses the blood-brain barrier. You guys are very knowledgeable. I love that. Identify possible consequences of suddenly stopping dexamethasone therapy. What happens when we just stop it? We don't just stop people who are using it chronically, right? We don't use them. We don't stop it. What do we do? We taper them off, we wean them off, we taper them. And sometimes we can have an immune system crash. We can have an adrenal system crash, right? Because it's going to cause acute adrenal insufficiency, all right? And so if that happens, it can take a really long time, and sometimes it may never it might not ever happen. We might have killed the adrenal glands, okay? So we have to be really careful with that. So we need to look for emergent signs of acute adrenal insufficiency, and we want to withdraw our steroids slowly, especially those long-acting steroids, right? So I like to use them short. I like to use them in tapering doses most of the time. You advise JS to take the prednisone at breakfast. Why do you want him to take it at breakfast? Why at breakfast? It mimics the normal cortisol production. So, so tell me, Michelle, when do we make cortisol? When do we make cortisol?
When do we make it? We make it at night while we're sleeping, and then it's released during the day.
Yes, you're exactly right. And so we make it during the night while we're sleeping. If you want to get a cortisol level to see how high it is. You want to get it about 4 o'clock in the morning. And then as we go throughout our day, we're going to be using up that cortisol. So somebody said, Abby said, we want to give it on an empty stomach. Do we want to give steroids on an empty stomach, guys? Why not? Why don't you want to give it on an empty stomach? What are the side effects of steroids, oral steroids? Bleeding, GI problems, gastritis. We can irritate the lining of the stomach, and we can cause a GI bleed. We can cause an ulcer, which will result in a GI bleed. Okay, so make sure that we're, in this situation, we want to give it in the morning, and we want to give it with some food. Yes. Synthroid levothyroxine should be given on an empty stomach. Thank you for that, Mo. JS states that his appetite has increased, but he is losing weight. He reports trying to eat, but he gets short of breath and cannot eat anymore. How would you address this problem? So your patient's a COPDer. And small meals, yep. Small meals is one. Calorie and protein dense. Okay, so before you go on, I want to know about carbohydrates. Kara, what do you think about carbohydrates? We want to be careful. We want to be careful with carbohydrates, right? We don't want them to have a big carb load. Because what do carbs do? They make us sleepy because they produce what? Besides fat. They turn to sugar, that's for sure, which increases our weight, but they actually increase CO2 levels. So and then you guys know what happens when you eat a big carb meal. It increases your fatigue, and of course it can cause problems with the respiratory. I want to nap every time I eat a carbohydrate. Okay, so and somebody said we want to give small bites, small frequent meals rather than 3 large meals. We want them to have softer foods. We don't want them to be expending their energy on trying to rest in between and trying to chew a steak, for example. What do you think about doing a respiratory treatment before a meal? Yeah. So you should really have them remember how that medication can alter the taste of things. So if this guy really doesn't have an appetite, you'd want him to really have the respiratory treatment like about an hour before his meal. And then, to rest, afterwards. Anything, and of course, conserve energy. So those are the kinds of things that we're going to be looking at. I gotta find my. Okay, you ask him questions related to the presence of gastric discomfort, vision, and joint pain. Why? Okay, what do steroids do? What are side effects of steroids? So tell me what do they do to your stomach? I already told you, right? It causes peptic ulcer.
So it causes bleeding, it causes fractures, and it causes visual problems too.
Yeah, so Christian is right, it causes osteoporosis, and that's where you would get the fracture from, right? So we always have to be concerned about our patients that are on chronic steroid use, about bone health and osteoporosis. And then Abby's right, they can develop cataracts as a result of long-term steroid use, okay? Differentiate between glucocorticoid and mineralocorticoid effects of prednisone. What's the primary effect of prednisone? What does it do? Why do we give it? It's immuno, right? So we're using it to suppress inflammation. We're using it to suppress the immune system. Okay, so there, when we use it, there should be minimal sodium and water balance issues. So we should have less of a problem with retention, with fluid retention, right? And fluid retention in a patient that has COPD is a big deal, can be a big deal, right? Because for lots of reasons, but because we could have capillary leak, which would cause him to have some fluid in the lung. How would your assessment change if JS were taking a glucocorticoid that had significant mineralocorticoid activity? One where there's a lot of sodium and water retention. So I think I already told you that, right? So you would be looking for fluid excess. If you have a steroid that has significant mineralocorticoid activity, you're going to be looking for sodium and water retention. So you're going to be looking for all those kinds of signs and symptoms. You're going to be looking for your edema, your fluid excess. Do I have JVD, for example? What about my urinary output? Because I'm holding on to that sodium and water, so I probably will have oliguria. And I already told you edema, and it might affect my respiratory situation. I might have crackles, I might become more dyspneic, I might have weight gain, and I may have changes in my potassium and my magnesium, okay? So I might have hypokalemia and hypomagnesemia if I'm using a mineralocorticoid type steroid, okay? Review JS's list of medication. Based on what you know about the side effects of loop diuretics and steroids, discuss the potential problem of administering these in combination with DIG. Okay, DIG toxicity. What else? If you're using prednisone and furosemide together, think about it. Potassium, yes. You're going to have hypokalemia. You could have hyponatremia, hypomagnesemia, okay? And so if you have hypokalemia, that increases your risk for DIG-induced dysrhythmias, okay? So we have to be careful with the combination of our medications, and we have to know which ones cause what and which ones we can use in combination, okay? Because that can cause lots of problems. I think we're almost done, I hope. You need to assess JS for signs and symptoms of infection. Why? I think you already told me this. We already talked about that, right? Suppresses the immune system. Yeah, we have immune suppression. And so remember that people who, you know, depending on your age, the age of a patient, and the fact that they're chronically immunosuppressed, they might not show the normal signs and symptoms of infection that others might, okay? That people who are not on steroids might. What signs and symptoms of infection do you assess for in JS? Select all that apply. Okay. So the answer is B, fever. But remember that fever is something that they may not be able to mount a response because they do have immunosuppression. And so remember, when we have immunosuppression, we have less surveillance. So fever is usually the cardinal sign that we would see in a patient that has an infection, but we might not see it in these patients, okay? Also, I know it's going to seem kind of fever. I already said that. Loss of function. I know that that's going to seem kind of weird, but that is one of the things that could happen. Unusual drainage is also the other one that you could see with patients that have that have an infection and are immunosuppressed. Realizing JS is susceptible to infection. Why? Oh. I said, did I not say that, Michelle? Did I say pain or not pain? Did I not include that? No. So the answer is pain, yes. So A, B, C, and E. A, B, C, and E, pain. Okay? So thank you for catching that. Keep me on my toes.
And one more question, I'm sorry, why not localized edema? Why would you not look for localized, like if I'm assessing for infection, I would think that looking for an area that would be like swollen.
Because remember that just like fever, sometimes you won't see that localized response.
Okay.
So let's say that you know, if you think, let's say they have a wound, you might not see the normal response that you would see in somebody that's not immunosuppressed. Does that make sense?
Yes, it does.
Okay. But it's a great question. Great question. Thank you for asking. Realizing JS is susceptible to infection, you review with him ways to reduce the risk of infection. Identify 4 major points to include. You already know this from our oncology section. How do we prevent infection? Hand washing. Just overall hygiene, right? Remember I told you that most patients that are immunosuppressed, they will get an infection from their own normal flora if they don't brush their teeth, if they don't shower daily, and all of those kinds of things. So good hygiene practices and good hand washing practices are imperative. Avoid large crowds, that's for sure. Stay away from groups of people that you know might be carrying some kind of viruses or bacteria, like little kids, school-aged children. Don't go to places like churches or places where there's the mall, the airport. My gosh, Atlanta airport, don't go there, okay? What else? No raw foods, right? Stay away from raw food. Get vaccinated if appropriate, okay? Report any signs and symptoms. Make sure that they tell their provider something, you know, if they think something's going on. They have to also be careful with pets, and they have to be careful with, you know, they have to be careful with, you know, soil and things like that. Like I love to dig in the dirt. I was doing that early this morning, but people that are immunocompromised should not be doing that. Okay. In addition to measures to reduce the risk of infection, what other information would you want to stress to JS at your visit? Select all that apply. Yes, it's terrible. It's terrible. Okay. Okay, so the answer is C, D, E, and F. Okay, C, D, E, and F. So when we're, so increased intake of water and sodium is not going to be correct, right? Because they're going to already be retaining sodium and water, which could lead to edema. So we don't want them to have more fluids, and we don't want them to eat foods that are higher in sodium. But we do want them to weigh themselves daily, right? And to monitor their weight gain. So if they gain more than 2 to 3 pounds in a day, that might indicate some fluid volume overload, and we would want to report that, right? D is also correct. Take vitamin and electrolyte supplements as are prescribed. Okay, so remember that they're going to be retaining sodium and water. C and D, yes, that's correct. And also E, notify the physician if the pulse is lower than 60 beats per minute. Okay. That could signal that, because remember this patient's on, we're kind of getting away from the patient, but remember this particular patient is on digoxin. So we're still talking about that same patient. And then F is correct, because we would want to know if the patient is gaining 2 to 3 pounds within 1 day. Okay, if you gain 2 or 3 pounds when you get up tomorrow morning, that's a problem. Okay. And this is a supplement for you. I think the rest of these slides are supplements, okay? Yeah. So then the rest of the slides are on Addison's, they're on, what else are they on? Should know this off the top of my head, but I can't. DI, SIADH, okay, they're all there, and I have put stuff down in the notes for you guys so that you can read them, all right? Was doing a case study helpful to you, that you're engaged? Okay, all right.